The Galien Foundation fosters, recognizes, and rewards excellence in scientific innovation to improve the human condition.
André Malraux said once in one of his novels, "Une vie humaine ne vaut rien, mais rien ne vaut une vie humaine." Human life is worth nothing, but nothing is worth a human life. All these men and women are trying to save human lives. Is there anything more noble than that?
Around the globe, the Prix Galien is considered as the equivalent of the Nobel Prize for the industry, mobilizing an unrivaled network of Nobel laureates and top biomedical scientists. The Galien Foundation manages an independent, cross-functional, and geographically diverse program of events and sponsorship to brand the best of the best in new medicines and diagnostics. The Prix Galien is a welcome initiative to stimulate creative research and promote excellence. Barack Obama. The Galien Awards ceremony is considered the equivalent of the Oscars night for the innovators in the labs and awards every year the best pharmaceutical product, the best biotechnology product, the best medical technology. The Roy Vagelos Pro Bono Humanum Award for Global Health Equity is bestowed to an individual, a company, an academic institution, or a non-governmental agency that has helped to improve the human condition through the application of biopharmaceutical science to problems of developing or underserved populations worldwide.
This is the right event, on the right issue, at the right time.
I thank His Excellency, the President, for bringing Prix Galien to Africa, and I look forward to the day when we will celebrate an African winner of the Prix Galien.
I'm particularly grateful to receive this award.
The awards are among the highest honors in science and commerce because they lead to improvement in the human condition.
The Prix Galien Awards recognize the world's brightest minds and most innovative companies. They are a true celebration of the hard work required to produce life-changing interventions.
That is what makes us optimistic about the future.
Congratulations to all of you.
Make a difference. Join the Galien Foundation.
Welcome everyone to the 2020 Galien Forum. My name is Michael Rosenblatt and I'm the Chief Medical Officer of Flagship Pioneering. It's a venture firm based in Cambridge, Massachusetts. And I'm honored to be co-chairing this wonderful annual event, now part of a 50-year-old tradition, with my co-chair, Susan Desmond-Hellmann, who you're going to be hearing from later today. I've had the good fortune to be part of the Galien Forum and the Galien Awards for many years now, and I'm so pleased that we've been able to find a way to celebrate innovation even in the midst of this pandemic. You know, for the last 3 days, we've been celebrating science and medicine in service of health through a series of sessions called the Galien Week of Innovation. We've been reviewing remarkable nominations for the Galien Awards, that's the Prix Galien, which are going to be announced tonight. And these awards are often referred to as the Nobel Prizes of the biopharmaceutical industry. But today, in the Galien Forum, we're going to look ahead to what the future of innovation in medicine and in health might look like. You know, there's no subject of more importance or more interest to people than health. And you just have to open a newspaper almost on a daily basis or watch the news on TV, and the chances are that there'll be a story about healthcare or a scientific breakthrough or a new medicine that's on the horizon. And there's no question that we need innovation in all aspects of healthcare, including providing access to these advances in medicine to people around the globe. But today we're going to put a spotlight on a particular category within the domain of innovation, which I'm going to call invention. Things that we can touch and feel, things like medicines, vaccines, and devices. And the biopharmaceutical industry has been intensely focused on these inventions. And in the past, we've seen how they transform lives. Just look at what the statins have done to reduce deaths from heart attack and stroke, or the HIV antivirals have done in successfully transforming AIDS, a universally fatal disease before these inventions, or prosthetic heart valves that have changed the course of heart disease for so many people. And even today, of course, we're seeing extraordinary efforts in productivity to make inventions to address the great pandemic, the COVID-19 pandemic. You know, the pipelines of the pharmaceutical and biotech industries and device industries now are filled with new modalities, things that we've never seen on the planet before. Living drugs are now, living cells are now called drugs, gene therapy, the microbiome, bugs as drugs. These things, these new therapeutic modalities, are changing the very definition of a drug. So today's Galien Forum is going to bring together leaders in academia, in government, and in industry to discuss the advances in the sciences fundamental to medicine. We'll discuss the future of innovation and, of course, the COVID-19 pandemic. So now let me introduce our keynote speaker, someone who needs no introduction anywhere in the world. Let's hear from Dr. Anthony Fauci.
Greetings. My name is Tony Fauci, and it is a great honor to address the 2020 Galien Forum about COVID-19. As shown on this first slide, the title of my talk is The Public Health and Scientific Challenges Associated with the Historic Pandemic of COVID-19 that we are currently experiencing. This slide is a shot of the cover of JAMA, the Journal of the American Medical Association, of a viewpoint that my colleagues and I wrote and published in January of this year. And as you can see from the title, it is Coronavirus Infections More Than Just the Common Cold. And I chose this title not to be facetious, but to remind the readers that we have had decades of experience with coronaviruses. In fact, if you look at this phylogenetic tree of the coronaviruses, you see that the human coronaviruses are in red letters, but also bats, for example, are very important reservoirs of coronaviruses. And they, in fact, have viruses that are strikingly similar to those that have infected humans. In the yellow highlighted boxes are the 4 coronaviruses that account for anywhere from 15 to 30% of the common colds that each of us experience repetitively year after year, particularly during the winter months. However, that all changed in 2002 and then again in 2012 when we were confronted with the first pandemic coronaviruses. That what was known as SARS in 2002 and MERS in 2012. So the severe acute respiratory syndrome was caused by a novel coronavirus that had pandemic potential and in reality created a pandemic of about 8,000 cases and close to 800 deaths, a high degree of mortality, but was not particularly efficient in spreading from human to human. And so it was controlled completely by public health measures like identification, isolation, contact tracing, and quarantine. 10 years later, the Middle East respiratory syndrome, again, a coronavirus of pandemic potential erupted in the Middle East and Saudi Arabia. It is still, to this day, having reintroductions. The original SARS was from a bat to a civet cat to a human, and the Middle East respiratory syndrome was felt to be a bat to a camel to a human. Now, where are we today? The third pandemic coronavirus, the syndrome of which appeared in the Wuhan district of China in December of 2019. The Chinese identified this as a novel coronavirus in the first week of January of 2020. And here we see it on the phylogenetic tree. And notice that because of its proximity phylogenetically to the original SARS that I mentioned a moment ago, it got the terminology SARS coronavirus 2, and the original SARS was called SARS coronavirus 1. And in fact, just to be clear on the terminology, the disease itself is called COVID-19, or coronavirus disease 2019, for the recognition of this new disease in December of 2019. And as I mentioned a moment ago, the virus that causes this syndrome is called SARS coronavirus 2. What is this virus doing to our planet? It has exploded in a manner that is unprecedented in the last 102 years since the 1918 infamous Spanish flu. With, as of just literally a few days ago, we had 40 million cases globally and 1.1 million deaths. The United States of America has been the worst hit country in the world with 8.1 million cases and over 218,000 deaths. The heat map of the states shown here indicate the number of cases per 100,000 population. Now, I want to take a minute or two to talk a little bit about the difference between the United States outbreak and the outbreak in the European Union, because it tells us a bit about responsiveness and the kinds of things that are going on now and that will go on. If you look at the blue line, the European Union peaked, particularly with the outbreak in northern Italy, France, and then Spain, with cases that are shown plotted here on the blue line. Note that when they recovered and shut down, they went down to a baseline less than 10,000 per day. In the United States, in which the peak early on was based predominantly on infections in the New York metropolitan area, as you could see, they peaked. But when they recovered, particularly the outbreak that was driven by the New York metropolitan area that accounted at one point in the spring to about 40% of the infections, hospitalizations, and deaths. When they recovered, however, our baseline in the United States did not go down below 20,000. As you can see, it hovered around there. That was due to the fact that there was eruptions in other parts of the country with community spread. When we tried to open up the country, as it were, the guidelines that were put forth in opening America again that were variably adhered to, we had a surge of cases that brought that baseline to about 70,000 a day, recovered a little bit, and now most recently, with the surges that we're seeing, we're averaging between 55 and 65,000 cases a day. Take a look at the European Union that did very well for several months, but then again, as the weather got a bit colder, and even before then, as they try to open up their economy, they skyrocketed up now to the European Union, having over 88,000 cases a day. But the question is, going back to April, May, and June, why did the United States never get down to a baseline that approximated that in the European Union? It depends really on, at least in part, to the extent in which one shuts down the country. If you look using GPS at mobility over time, for example, in parks and outdoor spaces, the United States did not shut down nearly as much as Italy and Spain, as shown in the light lines compared to the dark line. If you look at things like workplaces, again, the United States did not shut down as much as Italy and Spain as representatives of the European Union. This was also very clearly seen when one looked at visits to grocery stores and pharmacies, again, where the United States did not shut down nearly as much as Italy and Spain. So that gives you a snapshot of the different dynamics and the different approaches from an epidemiological and public health standpoint in those two important regions of the globe. Let's take a quick look at the virology, as I mentioned and shown on a previous slide. SARS coronavirus 2 is a beta coronavirus, an RNA virus with 4 structural genes, the most important and studied of which is the spike protein with its receptor binding domain that binds to the ACE2 receptor, which is the cellular receptor for SARS coronavirus 2 that's widely distributed in the upper and lower respiratory tract, the GI tract, and other tissues such as cardiovascular tissue and some endothelial cells. The transmission, as we now know, is by respiratory transmission, including large droplets, the kind that stay in the air for a very brief period of time, leading to the distance recommendations of 6 feet or more. However, recent data indicates that aerosol transmission, namely particles small enough to remain in the air for more than just a few seconds and have extended flowing about over time and distances. The exact degree or relative importance of aerosol is not entirely clear, but we know that at least is a part of the transmissibility. The virus is found in a number of different bodily fluids, but its role in transmission is unclear and likely minimal, if at all. Now, the risk of transmission varies by the type and duration of exposure, as well as other factors such as the viral load in the upper respiratory tract. Transmissions are seen in household contacts, in congregate, or even in healthcare settings where there is not available PPE or the PPE is not properly used. We also see outbreaks in closed settings, cruise ships, nursing homes, prisons, and factors that may increase the risk of airborne transmission are crowded and closed spaces, particularly in those where there's poor ventilation indoors. This becomes particularly problematic as we enter the cooler season of the fall and the colder seasons of winter. It's important to point out that you do not need to sneeze or cough to transmit. It is transmitted by singing, by speaking loudly, or even by breathing heavily. This graph from the CDC shows some of the risk places where transmissibility occurs, particularly restaurants that are closed and at full capacity with poor ventilation, gyms, bars and coffee shops, as well as certain religious gatherings. A very important component of this infection is that about 40 to 45% of the people who are infected are in fact asymptomatic. And modeling studies show that a substantial proportion of transmissions actually occur from an asymptomatic person to an uninfected person. This leads to now the very strong recommendation that I and my colleagues have been putting forth for some time now, is that fundamentals for the prevention of the acquisition and transmission of SARS coronavirus 2, the universal wearing of masks or cloth coverings, maintaining physical distance, the 6-foot rule that we talk about, avoiding crowds and congregate settings. This is particularly important and even more important when you're talking about indoors. And in that regard, try to do things outdoors much more favorably than indoors. And finally, the frequent washing of hands. The clinical manifestations are protean, but the early clinical manifestations are very much similar to what we call a flu-like syndrome, as shown as the percentages on this slide. In addition, in some patients, there's a curious loss of smell and taste, which precedes the onset of the respiratory symptoms. Now, for those who do develop symptoms, they are mild to moderate in about 80% of individuals. By mild to moderate, we mean not necessarily requiring any medical intervention except staying home and out of society. However, about 15 to 20% of people have severe or critical manifestations. And in those, the case fatality varies from a few percent to up to 20 to 25% of those individuals who require mechanical ventilation. The manifestations of severe disease are many, the most predominant of which is acute respiratory distress syndrome, or ARDS. However, we find by further and more clinical experience that we're seeing unusual manifestations like severe cardiac dysfunction manifested by arrhythmias, cardiomyopathies, and sometimes sudden death with cardiac arrest, neurological disorders, kidney disease, a curious hypercoagulability manifested by microthrombi in small vessels, and thromboembolic phenomenon leading sometimes to acute strokes in otherwise healthy individuals, and a very interesting multisystem inflammatory syndrome in children, which is very reminiscent of Kawasaki syndrome, seen anywhere from 1 to a few weeks following infection in children. In addition, we're starting to get more and more information about what's referred to as a post-COVID-19 syndrome of individuals who weeks and sometimes months or more following virological recovery report signs and symptoms such as extreme fatigue, shortness of breath, dyspnea, particularly climbing stairs or doing exercise, a dysautonomia, temperature dysregulation, sleep disorders, as well as what individuals are referring to as brain fog, or a inability to focus or concentrate. Now, the people who are at increased risk for severe COVID-19 illness, older adults, namely, if you look at this next slide, it's very telling. If you look at the rate per 100,000, rate of hospitalization per 100,000 population, as you can see here, a number of individuals in the lower age group compared to the elderly 75 years of age or over, a dramatic difference. And people of any age with certain underlying medical conditions. These are some of the conditions associated with an increased risk for COVID illness. Paramount among these are obesity, heart conditions, chronic obstructive lung disease. There are other conditions that may be associated with increased risk, and they're shown on this slide. I point out diabetes mellitus, hypertension, as well as immunocompromised states due to other diseases. Very important are the racial and ethnic disparities that we see in the United States, where African American and Latinx have a higher incidence of infection in the first place, usually on the basis of the jobs they generally have, putting them out in society in contact with people, and the increase of prevalence and incidence of the comorbidities that they have, much more out of proportion compared to the general population. The comorbidities, such as the underlying diseases that I mentioned a few slides ago. This is a telling slide. If you look at the rate of hospitalization per 100,000 population, the Hispanic, Latinos, American Indians, Native Americans, and Blacks in the 300 plus compared to white at 86. Therapeutics, we have established at the NIH a expert treatment guidelines panel made up of clinicians with experience in treating this disease from throughout the country and the world, who meet online regularly to develop a living document that's updated on a regular basis, providing the latest information on the clinical management and treatment of people with COVID-19. It's easily accessible on the website shown on this slide. If you look at the therapeutics for COVID-19, if you look at the bottom part, there are some that are under clinical trials, such as antivirals, convalescent serum, hyperimmune globulin. Very cautiously optimistic about the possibility of monoclonal antibodies directed against the virus. However, there are two that are actually recommended by the guidelines panel that have been tested in randomized placebo-controlled trials. For example, remdesivir, in a randomized placebo-controlled trial of over 1,000 people, showed a significant diminution in time to recovery of hospitalized patients who had lung involvement. Another randomized placebo-controlled trial from the United Kingdom of over 6,000 patients showed that individuals who had advanced disease, hospitalized, requiring ventilation, or high flow oxygen, when given dexamethasone as opposed to placebo, had a substantial diminution in the 28-day mortality. And finally, with regard to vaccines, we have developed what we call a strategic approach to COVID-19 vaccine research and development, in which we have what's called a harmonization of the protocols. There are 6 candidates that are being supported directly or indirectly for trial in the United States. I'll get to them in a moment. The coordination and the collaboration and the harmonization of the protocols mean that we have a common data and safety monitoring board, common primary and secondary endpoints, and common immunological parameters that are used to develop correlates of immunity. These are the 3 separate platforms that are currently being tested in the 6 trials that are ongoing in the United States. Nucleic acid, namely mRNA, viral vectors, chimp adenovirus or human adenovirus, as well as vesicular stomatitis virus, and then the protein subunits that are the classic vaccines that have been used for years. On the right-hand part of the slide, you see that there are 5 out of the 6 that I mentioned are in phase 3 trials, 2 of which began on July 27th. So I can predict, I believe with some degree of certainty, that by the end of November, beginning of December, we will know, based on the size of the trial and the rate of infections that are ongoing in this country, we will know if we have a safe and effective vaccine. I feel cautiously optimistic that we will have a safe and effective vaccine, even though you can never make absolute predictions when it comes to vaccinology. The reason I feel cautiously optimistic is that the data from the animal models, as well as the preliminary, not preliminary, but early data that we got from the phase 1 trials, showed that these candidates induce a degree of neutralizing antibody that is comparable, if not exceeding, what we see in natural infection in convalescent plasma. I want to close by showing this slide, which is the COVID-19 Prevention Network website that you can access to learn a bit about the trials that are going on, but also if anyone feels they would like to at least consider the possibility of entering one of these clinical trials, that you can express your interest without any obligation and learn more about this. So thank you very much for giving me the opportunity to make this presentation. I would like to extend my sincerest congratulations to my colleague and friend, William H. Fagey, who will be awarded the Roy Vagelos Pro Bono Humanum Award for Global Health Equity. I had the great privilege to receive this honor myself in 2013 from the Nobel Peace Prize laureate, Elie Wiesel. Bill, congratulations on an extraordinary career and for being selected for this important award. Thank you all for the opportunity to speak